It's a great pleasure now to introduce our next speakers. So, if I could invite Redmond and Russell to the stage, please. Let me take that one off. Thank you very much. Now, if I could just introduce Redmond from InterSystems and Russell from Ummanu Health, is that correct? And we're going to hand over to you, and very much looking forward to your talk this morning on using intelligent automation to mitigate pressures in the NHS.
Thanks, Shane. Thanks to you all. What a morning it's been. Can you all hear me at the back? Yeah? Good. That traffic, goodness me. Did everyone know there was going to be a train strike? Goodness me. Now, maybe before we kick off, just to get a sense of you as an audience, would you mind putting your hands up? Are you a provider currently to the NHS? Would you mind just giving us a show of hands? Current provider to the NHS. Okay. Now, if you are a current startup or an innovation startup, would you mind raising your hand? Okay. And working within the NHS itself? Okay, super. Okay, lovely. That gives us a sense of it.
It does.
So, thank you for being here. Thanks for taking the time out. I'm Redmond O'Leary, and I work for InterSystems. We have a stand down below. So if you're looking for the best freebies here today, definitely make your way to our stand, and we'll look after you. There's members there from InterSystems and Ummanu. And who are InterSystems? For those of you who don't know, about 60% of the current data flow from the NHS flows through our technology directly, and that's excluding working with partners such as Ummanu. And on a global scale, we've been running for about 45 years and using our technology, circa 1 billion of the world's population's records are stored on top of our data platform. We have a whole variety of partners around the world. So that's a sense of who InterSystems are. Now, we're here today with Ummanu, one of our partners. If you remember last year, we had another partner. This year, we've brought Ummanu with us. Maybe let's kick off. Russell, would you mind telling the audience a little bit about you? What's your backstory?
So I'm Russell Blackmore. I've been working in primary care IT for 34 years. So quite a while. Been in and out of national programs. Seen the national program for IT come and go at the beginning of the turn of the century. Thought I'd escaped, got out and did 3 years of consultancy, but I find myself drawn back in because it's a hard drug to give up.
And what about Ummanu? Can you give us a sense of what do Ummanu do in the UK?
So Ummanu is a technology that was born from a large provider organisation. So an organisation that was responsible for the urgent and same-day care for 5 million people. And they had real problems because they were trying to do a lot of this using telemedicine, and they had horrible problems with efficiencies. So they decided to solve the problem themselves. They built a piece of software, and after a while they realized that the software was doing a good job, and so they decided to spin it out and create a standalone business and offer that benefit to other clients. So we've brought it to the UK, and we're currently looking at the urgent care market and also working with some large pharmacy providers.
Okay, super. And as some of you have heard already today, and no doubt a number of you know, there's a problem and there are issues. And here is the issue. Here's the backstory. This is where we're at. This is what we're dealing with. Would you like to talk to that, Russell?
Yeah. I mean, I say I've been in the industry for 34 years, and you keep thinking you've seen the worst of it. Obviously, COVID took a side swipe for everybody. But it's not just that. You've got an aging clinical population, so you've got lots of people retiring from primary care. We've got 7.8 million people on the waiting list, which is an astonishing number. And of course, what does that do to primary care? It means people that would have been fixed in some way because they're waiting for treatment are now cycling back around the system because they need more pain relief, more support in some way. I said you've got a shortage of clinicians, and in urgent care especially, as you come into winter, you have an astonishing challenge because, I was in Liverpool 2 weeks ago, and already the discharge time, getting people out of an ambulance, was up to 15 hours. And talking to one of the urgent care providers last week, their busiest day now, Monday morning. Not the weekend, not out of hours, but actually Monday morning, because people are trying to contact their GP surgery and they can't. And you know, the point of access is becoming really challenging. So you've just got far too much demand and not enough clinicians to meet it. And I think, you know, one of the comments that was made in the last presentation that really stuck with me, one of the things you need to do, save time. Try and save time for people so that they can actually deal with the workload.
Yeah. So there's fires everywhere, yeah? Fires all around us. And, you know, how do you feel about that? What do we do? You know, we have to look to see, well, how do we create fire breaks? How do we fix this problem one step at a time? Russell, how would you relate creating fire breaks within the NHS to Ummanu?
Well, so first of all, we're not miracle workers. So we've looked at a very specific issue. So where clinicians have to make calls out to patients, which is particularly the case in urgent care. You have a big work list coming in, people are going via 111 online, they're phoning 111. Depending on the way the clinical triage works, those referrals will get fired off to different organisations, and a lot of them come into the urgent care partners that we're working with. And so you just have a very long work list, and somehow you have to decide what's important and then try and contact that patient. Generally, before you contact the patient, you're going to review their notes, you're going to prepare yourself, and then you're going to start ringing, and then you don't get them. Mm-hmm. And you try again and you still don't get them, and you try again and you still don't get them. Now, depending on the acuity of the case, you're actually allowed contractually to say, okay, I've tried several times, that's it. That case is now, you know, closed, yeah. Which ain't great for the patient, because they may need some help. But obviously you're just wasting time, so you've got to then go back around the loop, choose another record, review it, now start the process again. So we've reversed it. So what we do is apply ruthless automation to the process of fetching patients. So people have had virtual waiting rooms. There's nothing particularly clever about that. Yeah. But what we do is we look at all of the inbound activity that's coming in from 111 and elsewhere. So some of it's coming from the 9 service. Some of our providers are doing Cat 3, Cat 4 ambulance validations to decide whether the ambulance should actually be dispatched or not. Those are really time pressured, so you've got to get those done within 20 minutes maximum. If you hit 30, the ambulance goes anyway, whether it's required or not. So it shocked me, actually, coming from GP primary care. This is less about the kind of the clinical work that you do and more about ruthless workflow. You've got to get the traffic through the system. So we take in all of the activity, we order it in terms of priorities, so we're putting the highest acuity cases at the top. We also have the ability to do some clinical streaming, so we can look at why the referrals come through, and we can think which is the most appropriate team to give the work to. Mm-hmm. And then we have an automatic dialer that is calling out to the patients using IVR and other standard technologies to explain who we are, bring them into a virtual waiting room, and then the clinician has 2 buttons to press. The first button selects the patient that's next for them. That gives them the opportunity to review a medical record in context, because they know they're about to treat that patient, so they're not going to waste any time. And then the second button, that starts the consultation. And I've managed to make it sound quite simple, but there's an awful lot going on under the bonnet, particularly around algorithmic understanding of the queue, because you need to know how fast things are going. So based on the velocity that we're calculating, we know when to start fetching patients, because you don't want them sitting in a queue for half an hour with nobody picking them up. Yeah.
So that workflow, so you're getting a sense that what we're talking about so far is about that process, and it was touched on earlier on. It's dealing with that workflow, and that's what Ummanu are doing. You're getting in there and creating this break in the system to help clinicians get on with doing what they're doing and clearing the backlogs.
Well, the obvious important feedback is that time that clinicians take to fail to fetch a patient. We've done the analysis, and it's between 3 and 8 minutes, depending on how hard they try. And over the course of a shift, that happens a lot. So working with partners, we've analysed the impact that we've had, and as an average, we're delivering 30% clinical efficiency. So the call rates are not amazing in this environment, and one of the reasons for those is that some of the calls you get are extremely complicated, particularly on the mental health side. You might spend quite a long time talking to someone because they're in distress. You may feel that you have to do a safeguarding referral after that, so that can take a lot of time. But there are also short ones. I need a repeat prescription, that's easy. But the average, when we picked up our clients, we're finding is about 2.6 to 3 calls an hour. And if you look at the volumes, so DHU in the Midlands, they take 4 million 111 calls a year. So if you imagine that 50% of those get referred on to an urgent care provider, so that's 2 million calls, but they're only doing 3 calls per hour per clinician. You need a lot of people. So 30% change doesn't sound perhaps amazing, but actually that's taken you to 4 and more. So already you've gone from 15% oversubscribed to potentially being in a position where you can spend more time with the vulnerable patients, and you can spend more time with some of the more difficult cases.
Super. And Q, as you've noted, we've avoided the health tech stuff, but Q this then is you got to put a cute animal up, and this is what these guys are doing, trying to deal with the patients, trying to deal with the pain and deal with the outcomes. But what we haven't talked about is the technology bit. Can you tell us a little about your health tech and what it is?
So the way I met Ummanu was I was doing some consulting on interoperability. I was actually promoting InterSystems product some of the time. I sold it to eConsult, who was sat here last year. Yep. And they came to me saying, how do we join up with some of the NHS systems? And I think that was a theme in the last talk. It's extremely challenging. Some of the interfaces across the NHS in this country are very old. If you look at the amount of data that's flying around in legacy messaging, it's probably 90+%. And you've got a real challenge to plug into all the different ecosystems and get the assurances that come with that to allow you to safely operate. So we've got a cloud SaaS solution, modern technology, all rather lovely microservices and RESTful stuff that I care not to understand anymore. My technical days are past. But when it comes to plugging into 111, it's an ITK message, and most people outside of health would have no idea what that means, and a lot of people inside health don't know either. But it's a legacy XML standard coming through a very proprietary message setup, and that's where people like you come in, because we were able to go, and from 0 to 6 weeks, we actually got live with assurance from NHS England, because we were using a component on your platform that became pre-assured out of the box and made a huge difference to us. So we were able to just get up, start extracting the data from the 111 flow, so we could inculcate ourselves, let it flow through to the legacy EHR, but take a copy, feed it into our own platform, and start doing our magic. And my advice to startups and people that are trying to break into this market generally, work with interoperability specialists, because it just saves you an awful lot of time and effort, and you don't have to learn things that have been learned a long time ago.
Wow, so you've hit us with quite a bit there. So out of hours, dealing with those issues that are live out there right now, dealing with trying to handle the fires. We see it day in, day out. This isn't easy. Previously, they talked about that, how hard it is to get into the NHS and to get your technology working. We can discuss that further with you. And you've touched on advice for startups. I find that it's really tricky for them just to they've developed something really innovative. They've realized there's a need for it out there, but it's making it real often is the difficulty in getting traction once you've built a viable product. Would you have anything else to add to that?
It also gives you some credibility, because if you think, all right, it's a strong InterSystems message, but if you're in 60-70% of the UK hospital market and someone's trying to help with elective recovery, then if you're using an integration platform that a lot of the technologists will understand on the other side of the table when you're pitching, it helps. It gives it credibility. People understand. And I think it's really important to be able to go and talk to customers in this environment and put forward a case where you've got credible architecture, a credible product approach, and be able to demonstrate that you understand the pitfalls of assurance and navigating a complex governance landscape. And so partnering with people that have done, trodden that road many times is generally good advice, I think.
And obviously you can go to our stand to learn any more information about InterSystems, so we're not going to continue on that vein. But I'll move probably to Q&A now shortly to kind of give you a sense of it. Obviously what we've shared is, you out there are looking to solve problems, whether it's to put out fires. We're doing more than just helping wildlife out there, we're helping us. It's about us as end users, to use the technical term, patients. It's all about the patient, isn't it?
Yeah, absolutely. And I particularly like the market segment that I find us focusing on, because 60% of the urgent care is actually delivered by social partnerships. So we've been working with their representative organisation, which is called Urgent Care UK. They're sponsoring innovation. So we just recently worked with the Warwick Innovation Hub, got together with a bunch of the UHUK membership, and actually worked with a couple of other real startup suppliers. We were the established market holder of the group, and we're looking at stringing together more in that workflow. I don't believe at this point that we're ready to say the computer will see you now. I don't think it's about that. I think it's about creating the space for clinicians to have an interaction with a patient. I think that does the patient an awful lot of good, because there's something about hearing it from a human being that you trust. But we're looking at other things that we can string into this automated workflow, because we've saved 30%. But what if we could digitize the note-taking by taking a transcript and presiding, put a large language model on it so that you can give a good quality summary? And what if we can manage some of the downstream stuff? Because to get back to your point about patients, I was talking to the chief exec from File Coast, and one of their frequent flyers is a lady that has a fairly chaotic life. Again, mental health issues, chronic asthmatic, and she phones out of hours a lot for care. But why? Because she lives in a flat that's full of mold. It's damp, and actually what she needs is a housing intervention. But when you're in urgent care and you're on this conveyor belt of meeting this enormous demand, which has been growing, I think, 7% year on year since 2012, how do you make the time? So if we can save time, we can then create the opportunities for those kind of patient intervention events that otherwise just won't happen.
And what's coming next for Ummanu? Where do you go here?
Well, we're working with some very big providers now, Derbyshire Health United being one of them. So we're looking at getting into the front eventually, so actually looking at 111 as well as the urgent care, which is off the back of 111. We're working with a large at-home pharmacy provider, and basically we're looking for opportunities where if you've got a lot of phone calls to make to a patient population, we think we've got a technology that will really be impactful in that environment.
You know where to go. That's the case. Well, let's go to Q&A. Anyone got any questions for Russell? Any queries? While you're making your mind up, there was one that you've touched on there, because we talk about clinicians, and certainly one thing that I see in InterSystems, we've got a team of our own clinicians. We have a cardiologist, we have a mental health doctor who's within the team. It's when you go to implement the product that's been bought, it's making clinicians comfortable. And earlier on, we talked about this, about using governance, education. How comfortable were the clinicians that you deal with, given the changes to this workflow process?
It's a really good question. The GPs initially felt very uncomfortable. They thought, hang on a minute, you're monitoring my every moment. You're now you're managing our behaviour. We don't like this. One of the points I didn't pick up on earlier, particularly around when you've got a big list in front of you that's not automated, people tend to cherry pick cases. I'll take that one. I like the look of that. So 2 pieces of feedback on both of those issues. One from a nurse first, which was really heartwarming, and it actually came out when she was supporting us in a demo to a new client, which was a golden nugget moment. But she said, before I was using Ummanu, I would go and choose cases that I was very confident I could deal with. So basically, she was narrowing down her field of vision to a very small number of things. Now she was presented with a green button. She's not sure what's behind it. And rather than being, overwhelmed by that, what she's reported was that she was now dealing with a far greater range of cases. She'd fantastically enhanced her own portfolio. She felt that she was getting, amazing personal development because now she felt able to deal with any patient rather than just looking for those, I'll say easy, I use the word advisedly, but looking for cases she felt comfortable with. From the GP point of view, after a few weeks, the attitude changed. And they said, actually, you know what you've done? You've democratized the workforce because we're all working now to a similar pace. Everybody is getting delivered cases at the same rate. And actually, I feel this is much fairer. So, you got a really, really strong feedback. And the other thing the clinicians like is, because it's an automated system, I said at the beginning, 3 strikes and you're out. Well, we don't have to worry about trying harder, so we can send out more calls. We can use IVR to say, are you okay? Are you feeling worse? Do you want to jump the queue? Do you still want the care? Do you want to drop off the queue? And so there's a big patient safety element to it because we're not losing patients. We can keep going and going and going. And we've seen so far that we're bringing in, I think it's an extra 15% potentially that otherwise might not get a contact. So, we've freed up the time, and we're now bringing in more patients, and that time that was freed is there to treat those extra patients. So I think that's a pretty good outcome.
Okay, super, Russell. Anyone in the audience got any questions? We've got a few more minutes left while we have Russell here. Russell and his team will be here all day at the stand if you have any specific questions for Ummanu as a partner. And I suppose all I would add would be is that our goal has been to help health tech startups. So we deal with mature startups, we deal with people straight out of college, whether it's a single clinician with a techie, whatever it might be. And that's where InterSystems is to provide that platform as we glide under the radar, supporting up from people literally just starting out all the way through to some of the world's largest, such as Epic, where their technology is built on top of our platform. So if there's no further questions, I'd look to say thank you very much, Russell. Thank you all for taking the time to listen to us, and I hope that was of interest to you. I certainly found that a lovely good news story and a lovely outcome at the end of that.
Thank you.
Yeah, cheers, Russell. Thank you.